Okay, everyone. Okay, on to the last session of the day. Now, I have the pleasure of chairing the session with Al-Marie, and we're doing the free papers. And this is a wonderful section because this allows people to share with us their research that they're doing in child health. So it's a really wonderful opportunity for people to partake in the Child Health Conference and to show us what they're doing. So I looked for a theme through all of these, and the theme that stands out to me most of all is KZN. Every single one of these is related to KZN. One person was only born in KZN, but it still counts. So we're going to start with Mark Willoughby, who is a registrar in KZN, and he's going to tell us about his MEd.
So I won't be talking about AIDS today. I did a study for my MEd. It's entitled The Delay and Poor Diagnosis of Down Syndrome in KZN in South Africa, a retrospective review of post-natal cytogenetic testing. Professor Colleen Aldous from UKZN and Dr. Mark Patrick from Maritzburg supervised me. Mrs. Sheila Covenich from the cytogenetics lab in Pinetown, Durban, helped me collect my data, and Professor Arnold Christensen, who's written a number of papers on Down syndrome in the last 20 years, helped me analyze my data and put this paper together. So as an introduction, Down syndrome is the most common chromosomal disorder amongst newborns, with a birth prevalence of approximately 2 per 1,000 live births in South Africa. And up until about 20 years ago, it was considered rare in Africans of South African origin, and it was a largely unrecognized problem. Before, most papers that had been published on Down syndrome alluded to the fact that it was rare in African infants, and the first paper that indicated that it was as common in African infants as other infants was by Adekuna in 1982, where he found a birth prevalence of approximately 1.2 per 1,000 in Ibadan, Nigeria. It was also shown that Down syndrome is more difficult to recognize in African or black infants, and there existed a high infant mortality rate of Down syndrome patients, resulting in a low population. Okay. As I go closer. Okay. I'm just scared of going. Okay. Okay, so there was also a high infant mortality rate. There was shown to be a high infant mortality rate of patients with Down syndrome, resulting in a low population prevalence, resulting in a lack of awareness in communities and at a clinic level. The many abnormalities associated with Down syndrome make early diagnosis important in its management, as early detection of treatable disorders associated with the syndrome may prevent further and irreversible physical disabilities. The high cost of medical care also highlights the need for largely preventative care in these patients. So the aims and objectives of my study was to establish an epidemiological profile of Down syndrome in KZN and highlight the issues that arise therefrom, as well as indicating the burden of this disease in the province, as well as assess clinicians' abilities to diagnose Down syndrome by looking at the age of cytogenetic diagnosis of Down syndrome, as well as a ratio of clinically suspected Down syndrome to cytogenetically proven Down syndrome. So to do this, we approached the South African National Blood Service cytogenetics lab in Pinetown. They do all the chromosomal testing for the Department of Health in KZN. We searched for all postnatal blood tests for suspected and confirmed Down syndrome over a 5-year period from January 2009 through to December 2013. And we recorded the age at which the test was done, the hospital where the test was sent from, and the type of chromosomal pattern for each confirmed test result. So this is the result. So over a 5-year period from 2009 to 2013, this shows all the tests that were sent for suspected Down syndrome. So the total of 1,578 tests were sent for suspected Down syndrome, and this is a row that indicates those that were confirmed. So 875 confirmed. And the ratio of that is 55.4%. Another way of saying that is that we correctly clinically diagnose Down syndrome 55% of the time. And as you can see, the ratio seems to be declining over the 5-year period. We then looked at the confirmed Down syndrome test results from the different hospital facilities, and we divided those hospital facilities in those that were specialist-driven and those that were non-specialist-driven, and then private facilities. There was a small number of hospitals that sent, from private facilities that sent tests to the SANBIS, most likely they would have sent private facilities send all their samples to private laboratories. So the great majority, 671, which is about 77% of our patients were diagnosed in the specialist-driven facilities. And a smaller number, 194, which is about 22%, were diagnosed in the non-specialist-driven facilities. That's about, but they represent more than 50%, it's about 55% of the facilities where tests were sent from. And then about 1% were diagnosed in the private facilities. Then we looked at the average age of diagnosis according to the facilities from where the tests were sent. So the specialist-driven facilities had the youngest average age of diagnosis, which is 11 and a half months. The non-specialist-driven facilities had a later average age of diagnosis of 13 months, that's about a year and 1 month. And then interestingly, in the private facilities, the average age of diagnosis was 90 months, that's about 7.5 years. To explain this, we postulated that these may represent some patients that did not get care and recognition that there were families that did not get the care and recognition that they deserved in the public sector and sought care elsewhere, resulting in a late presentation to these facilities, resulting in a late age of diagnosis. And then these are the proportions of the different types of chromosomal patterns that we had out of those 875 patients. So 92.8% were non-disjunction, 5% translocations, and 2.2% mosaic. This is pretty much similar to what you'd read in most textbooks about Down syndrome. And then we looked at the average age of diagnosis according to the different types of chromosomal patterns. So non-disjunction was diagnosed at an average age of 1 year and 1 week. Translocation was a bit younger at about 5 months, and then mosaics were diagnosed at 1 year and 9.5 months. We know that mosaics may not carry all the phenotypic features of that the translocation and non-disjunctions carry, so that might be why they recognized a bit later and diagnosed a bit later. So overall, over the 5-year period, out of all our patients, the average age of diagnosis was 1 year and 20 days for a Down syndrome child. The total number of confirmed Down syndrome patients was 875 in the 5-year period. The total number of live births recorded in KZN was 1,046,622. And you can calculate the population prevalence from this. It works out to 0.8 per 1,000, or 1 per 1,205. So there's a number of limitations to this study. Firstly, patients may have been correctly diagnosed without chromosomal testing done at a later age. This may give our age of diagnosis to be later than what it actually is, or with chromosome testing not done at all, because Down syndrome is largely a clinical diagnosis. So then our population prevalence would have been lower than what it actually is. But from what we showed, we correctly clinically diagnosed Down syndrome only 55% of the time. This is, when you compare this to a developed world, we looked at the epidemiological study of Down syndrome in the Netherlands. They correctly diagnosed Down syndrome 83% of the time, and the average age of diagnosis was 1.8 days in hospital and 10.2 days for those born outside of hospital. So we're doing a lot worse than what they're doing in a first world setting. So what about antenatal testing? It is available in South Africa, but only really in academic centers, and even then it's not really done, or it's poorly undertaken. In a study of 48 women over the age of 35 who presented for care of their pregnancy before the gestation of 20 weeks, it was found that not one had been offered counseling for the prenatal diagnosis and cytogenetic testing. As well as in a study from Cape Town, more recently in 2011, the Down syndrome population in that study, they found that only 6.6% to 8.6% had been diagnosed prenatally. So the diagnosis of Down syndrome is largely the responsibility of the healthcare workers that come into contact with these children in the postnatal period. So in terms of mortality, congenital heart disease, which occurs in approximately half of all infants and children with Down syndrome, along with infections and malnutrition, have been shown to be the most significant cause of infant mortality or mortality of Down syndrome children in South Africa. In our study, the birth prevalence was approximately 0.8 per 1,000. This is 2 times lower than the birth prevalence that has been shown in other areas of South Africa. Fenter et al. Found a birth prevalence of 2.1 per 1,000 in Limpopo, and Kronberg et al. Found prospectively found a birth prevalence of 1.8 per thousand in Soweto, Johannesburg. So why is there such a large discrepancy between the birth prevalence and the population prevalence? So maybe some patients weren't diagnosed. That would be the reason for that. But also we feel that given the apparent lack of ability or inability to diagnose it, it may be the case that a lot of patients actually die before they're diagnosed. And in a study of intellectually disabled children between the age of 2 to 9 in a rural community in Mpumalanga called Bushbuck Ridge, the authors found that 2 out of every 3 children with Down syndrome died before the age of 2 in that study. So it may be that Down syndrome children are in KZN and in South Africa at large are dying before they're diagnosed, and their deaths being recorded incorrectly as something else. And the impact of Down syndrome is therefore probably not recognized as a public health issue in South Africa. So in conclusion, despite the limitations of the study, it is evident that the postnatal diagnosis of Down syndrome is a problem, resulting in missed opportunities for early intervention. It may also be shown that we may also say that many children with Down syndrome may in fact die before they are diagnosed, resulting in the impact of Down syndrome as a public health issue not being recognized. If diagnosis is the first step in the clinical pathway to caring for patients, and if the diagnosis of the most well-known and well-researched chromosomal genetic disorder is as poorly as we described in this study, what about other less well-known, less easily recognizable syndromes and conditions? And the answer is that they're probably quite dismal. In 2010, the World Health Organization, World Health Assembly issued Resolution WHA 63.17, in which it urged developing countries to recognize congenital disorders as a public health issue. They stated that congenital disorders will be the reason why developing countries fail to reach Millennium Development Goal 4. So there's a great need to increase awareness and improve on services for the care and of children with Down syndrome and other congenital disorders in South Africa. Thank you.
Okay. Mark, you did good in time. Questions for Mark? Any questions?
Okay, thanks.
Thanks very much. There's one question, Mark. You're not going to get off the hook.
Is better. I guess, I don't know whether you would have been able to know from just the laboratory records if these were also tests done for children with other suspected genetic abnormalities, or was it specifically that Down syndrome was suspected, or was this a child that looked dysmorphic and there was just,
It may have been, but so there's a form that you send to the laboratory. You take a blood sample, you send a form, and on it you say what you suspected syndrome is. So we just took it according to the form. They wrote Down syndrome, we took it according to the form.